Hello everyone, good morning. Today we are going to see about approach to pediatric leukemias. I am Dr. Rishika from Pediatric Department, Lakshmi Narayana Medical College. So coming to childhood cancers, most common childhood cancer is acute lymphocytic leukemia, which has a prevalence of 23%, followed by other cancers. So most common cancer in childhood cancers is blood leukemia, that is acute lymphocytic leukemia. And in solid tumor cancers, it is a brain cancers which comprises all types, followed by neuroblastoma, Wilms tumor, rhabdomyosarcoma, retinoblastoma, osteosarcoma, and Ewing sarcoma. So before jumping into the topic, just we will go through the history of leukemia. In 1845, the Craig and Bennett discovered a case as a separation of blood. So the Victor discovered this as well, named it a leukemia. In 1855, the Ernest Newman discovered that bone marrow was the likely origin of leukemia. So in 1946, the Sidney Farber used antifolate agent to treat the leukemia in children. In 1960, the addition of vincristine and steroid to the regimen has begun. So it increased the survival rate much better, which increased to over 50%. And in 1970, they used a they begin the classification and they discovered more the discovery of cytogenetics and risk-based treatment, which almost increases the survival rate more than 80%. So coming to the acute leukemia. So acute leukemia is more common in the childhood period. So in childhood, in acute leukemia, the more common is acute lymphoblastic leukemia, which has 75% of incidence, followed by acute myeloid leukemia, which has 20%, followed by undifferentiated leukemia and acute myelomonocytic leukemia. So what is actually leukemia means? This acute leukemia, which represents the arrest at a specific stage of the lymphoid or myeloid hematopoiesis and the clonal expansion. So, if the during the hematopoiesis, either it can be either lymphoid or myeloid, if there is arrest at a specific stage, and at that stage there will be a lead to the clonal proliferation of the cells. So, it will represent as a acute leukemia. So coming to the chronic myeloid leukemia, which consists of only a minimal prevalence, that is 3%, that is Philadelphia positive chronic myeloid leukemia and juvenile myelomonocytic leukemia. So most common pediatric malignancy, as earlier said, it is acute lymphoblastic leukemia. This is the slide of the acute lymphoblastic leukemia. You can see the immature lymphoblast in present in the peripheral smear. It comprises 25% of pediatric cancer, which include both blood malignancy and solid organ malignancy. So when it is more common. So mostly acute lymphoblastic leukemia is common in children. It is 1 to 8 years of age is most common, but the sharp peak attained among the children aged 2 to 3 years. So with the rate decreasing for more than 8 years. So the incidence of ALL among the children aged 2 to 3 years is fourfold greater than of the infants and fourfold to fivefold greater than for the children aged 10 years and older. And it is more common in boys than in the girls. So before going to the pathophysiology, we will just go to the common normal physiology of our blood stem cells. So we have everyone will have a multipotent, pluripotent, hematogenic blood stem cells. These stem cells can differentiate it into multiple stem cells. So only we are calling it as a pluripotent stem cells. So first, this stem cell from the bone marrow will either it can be differentiated into myeloid stem cells or it can be either differentiated into the lymphoid stem cells. So coming to the lymphoid stem cells, this lymphoid stem cells will after differentiation into the myeloid and lymphoid lineage, they will go according to their lineage. So if the lymphoid, if the stem cell multipotent stem cells is differentiated into the lymphoid stem cells, then it will go into the lymphocytic lineage. So this lymphoid stem cells will differentiate into the lymphoblast, and this lymphoblast further has a maturation and differentiation to release into the peripheral circulation as a B lymphocyte and T lymphocyte and natural killer cells. So if the blood stem cells is differentiate into the myeloid stem cell, then they will go according to the myeloid stem cell lineage. So these myeloid stem cell differentiate into myeloblasts. If they differentiate into the myeloblasts, they will mature into granulocytes like eosinophil, neutrophil, basophil, which will release into the peripheral blood stream. And if the myeloid stem cells has a differentiate into the erythroblast, they will differentiate as a mature as a red blood cells. And if the myeloid stem cells went into differentiate as a megakaryoblast, they will mature as a platelet. So if there is any arrest in this blast stage, then they will lead to the clonal proliferation of either lymphoblasts, then it will termed as a acute lymphoblastic leukemia. If they have a clonal proliferation of myeloblasts, then it will come into the acute myelocytic leukemia if it is in an acute onset. So this is the main pathophysiology of leukemic origin. So previously, we used to classify the acute lymphoblastic leukemia into FAB classification or WHO classification. FAB classification is nothing but it is a French, American, and a British classification. But nowadays, present days, we are not using it much often. Now we are just following a WHO classification. So in the past, they used the ALL lymphoblasts were classified using French, American, British criteria. So that is AL1 morphology, L2 morphology, and L3 morphology. Present days, this is no longer used, and because of the lack of independent prognostic significance and the subjective nature of this classification system, we changed into the WHO classification. So what are the risk factors for ALL? So exact etiology is unknown, but the primary accepted risk factor for ALL is prenatal exposure to X-rays and postnatal exposure to high dose of radiation and previous treatment with chemotherapy. So apart from this, there are the genetic condition which also proposes the risk for ALL, that are Down syndrome, neurofibromatosis, Bloom syndrome, Fanconi anemia, ataxia telangiectasia, Lee-Fraumeni syndrome, and constitutional mismatch repair deficiency. These Bloom syndrome, Fanconi anemia, ataxia telangiectasia are DNA repair defects. So it can arise to any malignancy, but most common it is a ALL. It can leads to a leukemia, it can leads to sarcoma, it can leads to other solid organ tumors. So coming to the siblings of, if the child has sibling of children with leukemia, the another child will have a slightly increased chance of developing leukemia, but comparatively, the overall risk is still low. But if they are identical twins, if one twin develop the childhood leukemia, the other twin will have more risk. That is 1 in 5 chance of getting leukemia. This risk is much higher if the leukemia develops in the first year of life. If the child, if the parent is having leukemia, the child doesn't have any increased risk of leukemia. It is the risk of leukemia in that child is equivalent to the environmental risk or population risk. So what are the signs and symptoms of ALL? So these signs and symptoms that reflect either if it is affecting the bone marrow infiltration or due to the extramedullary disease. So if first we can see how this bone marrow infiltration will shows the signs and symptoms. So because of the clonal proliferation of the immature cells, so the maturation of all the cells will be arrested. So there will be a decrease in all the cell lineage. So they will have anemia, they will have neutropenia, they will have thrombocytopenia. Maybe this 1 to 2% may be present initially as a pancytopenia, which will wrongly diagnosed as a misleading us to the aplastic anemia or bone marrow failure. So apart from this, they will have a general or systemic symptoms like fever, 60% because of decreased neutrophil count. They will lead to the neutropenia, and sepsis is rarely seen. So they will have easy fatigability, and they will have a pallor due to a decreased hemoglobin. And what is the clinical manifestation of extramedullary involvement? If extramedullary involvement other than the bone marrow, the leukemic cells proliferated into the other sites and they are occupying the other area than bone marrow. Then they will have the signs and symptoms specific to the region. So if the leukemic cancer cells are present in the CNS, then the CNS involvement will present as a raised intracranial pressure, meningeal or parenchymal involvement, which can be as a cranial nerve palsies or CNS hemorrhage or chloromas of spinal cord. And mostly CNS involvement is less than 5% at the initial diagnosis. If it is involving the testes, then it will have a painless enlargement and occult testicular involvement in 10 to 33%. And if it involves the lymph node, that is lymphadenopathy is more common, that is 50%. If this leukemia patient will have a lymphadenopathy, they will have a bulky mediastinal lymphadenopathy, then they will cause a superior vena cava syndrome or superior mediastinal syndrome. This is more common in the T-cell leukemia in adolescents. If they involve bone and joint involvement, they will present as a bone pain. This bone pain is the most common, one of the initial symptoms in 25% of children. Why it's so? It's because the direct leukemic infiltration of the periosteum or direct bone infarction or expansion of the marrow cavity, which will leads to the bone pain. So how it will be showed in a radiological x-rays. So they will present as a osteolytic lesion involving medullary cavity and cortex. And there will be a transverse metaphyseal radiolucent bands. And there will be a transverse metaphyseal lines of increased density, that is growth arrest lines, and subperiosteal newborn formation also can be seen. Other than this, they can involve spleen, it will lead to the splenomegaly, they can involve liver, it will lead to the hepatomegaly, and they will involve the serous space, that is pleural and pericardial effusion. If it involves the skin, it will produce as a neonatal leukemia. It will produce as a purpura or ecchymosis, confusions. So it is most commonly seen in the neonatal leukemia or AML, and it can present as a priapism, and renal involvement also can be seen, which will lead to the kidney injury, and gastrointestinal involvement also seen. Gastrointestinal involvement, the most common manifestation is bleeding. Why it's so? Because the leukemic infiltrate will clog the blood vessel, which will lead to the necrotizing enteropathy, and the most common site is cecum. So coming to mediastinal mass, it is most commonly seen in T-cell ALL with a high initial white blood cells count and can be associated with the pleural effusion. So if there is a mediastinal mass, it can lead to the complication as a superior vena cava syndrome. If the mediastinal mass keeps on increasing, and increasing size will compresses the superior vena cava. So the blood from the head and neck is obliterated. So what will happen? There will be congestion, swelling, plethora or sinuses of face, neck and upper extremities, and conjunctival suffusion will be there, and engorgement of collateral veins and altered mental status due to decreased cerebral blood flow will be seen. So this is the superior vena cava. If this mediastinal mass it's rather than compressing the superior vena cava, along with it, if it compresses the trachea, then it will call the superior mediastinal syndrome, which will associated with respiratory symptom also. Along with the superior vena cava symptoms, they will have a respiratory symptoms in superior mediastinal syndrome, which will present as a cough, hoarseness, dyspnea, orthopnea, wheezing and stridor, dysphagia and chest pain, altered mental status and syncope can be seen in superior mediastinal syndrome. This superior vena cava syndrome and superior mediastinal syndromes are oncological emergency. You need to be treated soon. So how we will diagnose this leukemia? So for whatever we are having that signs and symptoms, the general symptoms will present as either a fever or easy fatigability or bleeding manifestation due to bone marrow infiltration or extramedullary symptoms. So first we will advise to take a blood count. So in blood count, in complete blood count, we can able to see the hemoglobin will be markedly reduced, so it will lead to the anemia, and white blood cell count will be increased due to the proliferation of immature leukocyte, but the differential count will be abnormal. And if there is if in ALL children this leukemic stage is surpass the bone marrow means, then there will be increased white blood cell count. That means if the leukemic cells is filled into the peripheral blood means, then it will shows also increased white blood cells. But if it is not spilled into the, if it is a early stage, still it is in a bone marrow stage, there can be even the white blood cell can be low or normal, and there will be thrombocytopenia. This 92% of platelet have platelet counts below the normal, so the coagulation studies should be done. Do in this patient, it's because the T lineage acute lymphoblastic leukemia is to assess for disseminated intravascular coagulation. Then we will see the peripheral smear. In peripheral smear, we can able to appreciate the blast cells. So these blast cells are nothing but the immature precursor of either lymphocyte or granulocyte. So they do not normally appear in the peripheral blood. But if they appear in the peripheral blood, we can easily recognize by their size, because they will be a large in size. They will have a primitive nuclei. That is, the nucleus will contain many nucleoli. The blasts are very few to none in patient with the leukopenia. So blasts are usually abundant, and eosinophilia is seen uncommonly in AML, and 20% of patients with AML will have a basophilia also. So coming to the blast, how the lymphoblast and myeloblasts can be differentiated. Both blasts are larger in size, but comparatively to the lymphoblast, myeloblast is little more larger. So size of lymphoblast is 15 micrometer and myeloblast is 20 micrometer. So the nucleus is round in lymphoblast and curved in the myeloblast. And in lymphoblast, the cytoplasm is scarce. Less. So the nuclei will be more. So there will be a high nucleus cytoplasm ratio because of larger nuclei and smaller cytoplasm. But it is opposite in myeloblast. Myeloblasts have a plenty of cytoplasm and a small nucleus. So the nucleus cytoplasmic ratio is low and they will have a smaller nucleus. So because of the less cytoplasm, they will have homogeneous chromatin, and in myeloblast it is a clumped chromatin. So coming to the cytoplasm, as I earlier said, cytoplasm is thin rim. They will have a little bit cytoplasm and there is no granule. So it is a granular. Because of no granular, so it has a myeloperoxidase negative. But in opposite, comparatively to myeloblasts, the myeloblasts have a abundant cytoplasm, so they will have more granular in the cytoplasm. Either it can be IRRs also can be seen. So because of this granular cytoplasm, they will have myeloperoxidase positive. So in your right hand side, you can see it is a lymphoblast which has a thin rim of cytoplasm. This cells has not that much of cytoplasm in C, but they have a larger nucleus, and inside the nucleus, you can able to appreciate nucleoli. But comparative to myeloblast, the nucleoli in lymphoblast is less. But coming to the myeloblast, in myeloblast, the cytoplasm is little bit more than the lymphoblast. So they have a granularity in the cytoplasm, and the nucleus is small comparative to lymphoblast, and nucleoli is present. So how you will see, how you will after this see in the peripheral blood smear, you will go for the bone marrow study. In bone marrow study, you need to see about the cellularity of your bone marrow. So normally bone marrow contains a certain number of blood forming cells and fat cells. If the marrow is with too many blood forming cells, we can able to say it is a hypercellular. If the marrow is having too few blood forming cells, then the marrow is hypocellular. So according to the marrow involvement, we can able to define as if marrow involvement is M1, that is only you are seeing less than 5% of blast cell, then we can consider it marrow involvement as a M1. M2 means it is 5% to 25% of blast cell you can able to appreciate in the bone marrow. M3 means more than 25% of blast cells is appreciated in the bone marrow. So almost all patients with ALL will present with the M3 marrow, that is more than 25% of blast cells. So the bone marrow, if you have a bone marrow aspiration and it has M1, that is it is more than 5% of blast, now you need to suspect the bone marrow. Sorry, if it is less than 5%, now there is no any suspicion of leukemia. But if the bone marrow aspiration has more than 5% of blast, now you need to suspect the leukemia. If the bone marrow blast is more than 25%, then it is diagnosed as a leukemia. So this is the after bone marrow aspiration. Then you will come across the immunophenotyping by flow cytometry. So there is a flow cytometry for each lineage. If it is B lineage, then you can able to get CD 19, 20, 22, 79, A facts by kappa and lambda. In T lineage means it is CD 2, 3, 5, 7, 4 or 8. In mylar lineage, it is CD 13, CD 33, CD 117 and myeloperoxidase positive CD50. If myelomonocytic 2 lineage means there is C monocytic lineage, that is CD14, 20, 64 and 163. Megakaryocytic, it is a 41 or 61, and a leukocyte common antigen, it is a 45. So B lineage ALL accounts for 80% of childhood ALL. So the B cell precursor of ALL. Earlier it can be a pre-B cell or pre-B cell or transitional pre-B cell, but these distinguishing this subtypes usually are not clinically relevant. So we are just differentiated into B ALL and T ALL just for a clinical treatment wise or a practical for practical purpose, but we are right now we are following the WHO classification. So after this, we will see we will request them to take a chest X-ray to see mediastinal mass and other blood investigation like uric acid and lactate dehydrogenase, liver function test, renal function test, and a tumor lysis syndrome panel, which is a comprises uric acid, serum phosphate, and serum potassium and serum calcium, and the cerebral spinal fluid to identification of blast cells on cytocentrifuge examination to exclude the CNS involvement. So then cardiac function to see ECG and echocardiogram and to rule out other infectious disease profile like by doing the hepatitis antibody screening, CMV antibody titer and HSV antibody titer. So after this investigation, we need to know about what is minimal residual disease before going to the treatment. So if there is a 5% blast in the bone marrow, then it corresponds to the level of 1 in 20 malignant cells. So what we used to do now, we will check with the PCR assays or flow cytometric assays. So if there is a higher level of this end induction minimal residual disease, then we label them as a poorer prognosis. Then those with the lower or undetectable levels. So, what is minimal residual disease after our treatment? If we are doing bone marrow, if in their bone marrow still they have a 5% blast, then we will regard it as a minimal residual disease. If it is more than 5% blast in bone marrow, that is a higher level of minimal residual disease. If it is less than 5% of blast in bone marrow, it is a lower or undetectable level. Then it will shows us a good prognosis. So in BALL, evaluating the minimal residual disease at 2 time points. One is end of the induction and another one is end of the consolidation. After by this, we will identify this patient into 3 categories. One is low, if they have a low or undetectable end induction minimal residual disease, then they are categorized into the best prognosis. If we have a detectable or a high minimal residual disease at end of the induction, but low or a negative at the end of the consolidation, now they will come in the intermediate prognosis. If they have a detectable or a high minimal residual disease at the end of the consolidation, now then they will come under the worst prognosis. In T cell ALL, the prognostic significance of minimal residual diseases is very low documented in a few studies. So coming to the risk stratification. By risk stratification and by the classification of the ALL, we will give them a integrated treatment management. So how we will stratify the ALL patient into the low and high risk. If the age is 1 to 10 years and initial count less than 50,000 and immunophenotypically they are under a early pre-B cell ALL, and in cytogenetics they have a hyperdiploidy and translocation 1221 chromosome and trisomy 4, 10, 17, and there is no CNS involvement, and pregnant and the response of steroid is good. That is at the end of the 8th day, the black cell response to the prednisolone steroid should be less than 1500. Then it is a good response. They will be under low risk. And post induction minimal residual disease less than 0.01 percentage. This patient has these futures, they will stratified into the low risk. If the patient has either the patient is less than 1 year or more than 10 years, if the patient's initial count is more than 50,000 and immunophenotype, they have a mature T cell ALL. In cytogenetics, they are the 922 translocation and MLL gene rearrangement and translocation between 119 or 1719 and complex karyotyping, and they have an involvement of CNS at the initial diagnosis, and there is a poor response to the steroid because of the day 8 blast is still more than 1500 and minimal residual disease after post induction is more than 0.01 percentage. They will stratify into the high risk group. Then we will modify their treatment to the high risk stratified. So these and all for clinical purpose, but there is no any uniform criteria for this stratification. So treatment first, whoever present with the leukemia, first you need to initially stabilize the patient because of the oncological emergency, and then you need to plan for the chemotherapy according to their classification and the risk stratification. So initial stabilization we will done by the blood product support and manage the infection, and we will prevent the tumor lysis syndrome. So what is tumor lysis syndrome? The 1 or 2 words about the tumor lysis syndrome. This is a criteria of tumor lysis syndrome. That is, we will differentiate the we will divide the tumor lysis syndrome into the laboratory tumor lysis syndrome and clinical tumor lysis syndrome. So coming to the laboratory tumor lysis syndrome, if they have 2 or more of the following occurring from either 3 days prior to or up to 7 days after the commencement of cytotoxic therapy. That is, if they have a uric acid more than 8 milligram per deciliter, or potassium more than or equal to 6 milliequivalent per liter, or phosphorus more than or equal to 6.5 milligram per deciliter, or either 25% increase from the baseline. Plus, if they have a calcium less than or equal to 7 milligram per deciliter, or 25% decrease from the baseline. In this, if they have 2 or more, then we will label them as a laboratory tumor lysis syndrome. And what is a clinical tumor lysis syndrome? Now, if they satisfy the laboratory tumor lysis syndrome criteria, plus if they have more than or equal to one of the following. Thus, if they present with the acute kidney injury, defined as the creatinine is more than or equal to 1.5 times the upper limit of normal, or the glomerular GFR is less than or equal to 60 ml per minute, and cardiac arrhythmia and sudden death and seizures we will label as a clinical tumor lysis syndrome. So how we will manage the tumor lysis syndrome? We will manage with the hydration at 3 liter per meter square with either with the 1/4 of NS or DNS, allopurinol, and urate oxidase drugs like rasburicase, and we will manage hyperkalemia, hypocalcemia, hyperphosphatemia. For infection, we will get PCP prophylaxis. So another oncological emergency, that is hyperleukocytosis. What is hyperleukocytosis means? It is a peripheral leukocyte count which exceeds more than 1 lakh per ml. So what is clinically significant hyperleukocytosis? Occurs clinically significant hyperleukocytosis in AML if it is more than 2 lakh, and other ALL and CML if it is more than 3 lakh. Why does AML alone have a low cutoff? Means in AML it is a myeloblast, and myeloblast already it is a more larger in size, and on the surface of the myeloblast there is a more sticky receptors are there. So it will adhesion to the blood vessel will causes more damage than other leukemias. So if in AML, if the child has a more than 2 lakh per 2 lakh cells, then we can able to we can take the child into clinical significant hyperleukocytosis, and we need to treat the child as early as possible. This will present as a death by CNS hemorrhage or thrombosis or pulmonary leukostasis or metabolic dearrangement of tumor lysis syndrome. So why it is so? As usual, as earlier I said, because of increase of the myeloblasts or lymphoblasts, these cells has a larger in size, so they will have a more viscosity, and because of the sticky particles which is present in the surface of this immature cell, they will be increased adherent to the blood vessel wall. They will lead to the thrombosis or embolic formation. So the most susceptible area is cerebral and pulmonary vasculature, and they also causes priapism, clitoral engorgement, and dactylitis occurs occasionally. So we need to manage by giving adequate hydration, and we need to give, if the platelet count is less than 50,000, we need to give a platelet transfusion. So in this patient, we need to avoid the packed red cell to increase, because if we give packed red cells, they will lead to the further increase in viscosity and further will lead to the poor prognosis, and coagulation abnormality should be corrected. Either we can do exchange transfusion or leukophoresis can rapidly lower the WBC count and may improve the coagulability. And systemic anti-leukemic therapy must be initiated as soon as emergencies are addressed. So there is no any proper protocol is available. So we are adapting the Western protocols. So this is the group ICEL, Indian Childhood Collaborative Leukemia Group. So it is based upon adapted response-based therapy, and because of this, improved supportive care and molecularly targeted agent and international collaboration have been done in this forum. So what are the chemotherapy protocol we are having? We are having BFM, UKALL, and St. Joe's total therapy. So most ALL is a systemic disease, and it is primarily based on chemotherapy we are treating. So depends on the risk, either it is a standard risk or high risk, we will made into a different phase. Protocol, and they have a different phases. One is induction. So induction is we are giving chemotherapy to achieve the remission. What is the remission means? After the period of induction, giving chemotherapy in induction phase, they should have a less than 5% of blast in bone marrow and recovery of blood count and no evidence of leukemia at the other sites. Then it is a complete remission. And after induction, we need to go for the consolidation phase. For why we are going to consolidation phase means to further reduce the leukemic cell burden before the emergence of drug resistance and relapse in other sites. That is testis or CNS. If at initial diagnosis they have a CNS involvement, then we will follow the protocol. So then after this induction and consolidation, we will go to the maintenance phase. That is the longest and last phase of chemotherapy. So these are the induction chemotherapy drugs used in induction phase, and these are the drugs, that is prednisolone, vincristine, daunorubicin, L-asparginase. L-asparginase is mostly used in a child, not in a adult because of the side effect. And these are the drugs are used in the consolidation phase. That is cyclophosphamide, cytarabine, 6-mercaptopurine. And if it is a CNS directed therapy, then we will use intrathecal methotrexate and protocol M, that is high dose methotrexate and cranial irradiation. In maintenance phase, we will use prednisolone, vincristine, 6-mercaptopurine, and methotrexate. So this is the ALL. So short points about AML. In AML, it is only 15 to 20% of leukemia in less than 15-year-old. Higher incidence is in infants and slight increase during adolescence. So this WHO classification defines 20% of blasts are required for the diagnosis. And in cytogenic abnormalities, if the patient has these cytogenic abnormalities, and regardless of the blast percentage, we will label them as a acute myeloid leukemia, that is translocation between 821 and inversion of 16 chromosome and translocation between 15 and 17. So we will treat the AML. We will treat by the induction and consolidation phase. Induction, we will give a 2 cycle, that is by cytarabine and doxorubicin, followed by the 3 cycles of consolidation with a high dose cytarabine. So in this also they didn't have attained remission. We will go for the allogenic hematological stem cell transplantation. So coming to acute leukemia and association with the Down syndrome. Down syndrome has a 10 to 20-fold increased risk of both ALL and AML. But if they are less than 4 years, they are more have a more incidence of developing AML, and more than 4 years they are more prone to develop ALL. In AML, they will have a more prone for M7 AML. So So AML in Down syndrome has a better prognosis than in a AML in non-Down syndrome. So what are the extremely poor prognosis in infant leukemia? If the initial, if they have initial high white blood cell count and massive organomegaly, CNS involvement, and failure to achieve the complete remission, and KALA or CD10 negative chromosome 11 abnormalities, that is MLL gene rearrangement, and greater resistance to therapy, they will have a extremely poor prognosis. So coming to the side effect in the childhood, this is the AML, and coming to the side effect in the childhood acute lymphoblastic leukemia. So because of your chemotherapy, even they can have a late effect of side effect in a leukemic patient. So lately they have lead to the secondary malignancy, and they will have a neurological or neurocognitive disorders and cardiotoxicity due to the anthracycline therapy, and endocrine disorders and bone disorders due to a steroid, long dose of steroid and other chemotherapical agent, and it will affect the social and psychological disorders. This is a short brief about the acute leukemias, covering most of the acute lymphoblastic leukemia and short on the acute myeloblastic myeloid leukemia, and a side effect of the side effect of chemotherapy in a ALL. So thank you everyone for your listening. We will meet in our next class.